All right, it looks like it's 11 o'clock. Good morning, everyone. Thank you for joining our fourth stakeholder sharing session, Oral Health Access. Before we get started, I wanted to cover just some logistics and ground rules for today's session. So right now, a majority of you are on the session as participants. However, once I'm done talking, I'm going to be switching everyone over to a panelist so that everyone will be able to hear and see each other. If you are only joined on the session using your phone, if you could just let us know who you are, either by shooting me a quick email, or if you want to come off of mute and just introduce yourself now, that would be great. All right, maybe our phones are connected to other videos then. So once we do switch you over to panelists, just note that if we hear a lot of background noise, we will be muting you. However, you can unmute yourself at any time to contribute to the conversation. And you can do that by clicking the unmute button. It's the little microphone in the bottom left-hand corner of your Zoom window. If you want to just temporarily unmute yourself, you can press and hold the spacebar on your keyboard when you're talking. So once we switch you over to panelists, you'll also be able to enable the gallery view, which enables you to see the most people on your screen. So you'll be able to do this by clicking in the upper right-hand corner. It'll either say speaker view or gallery view. So you can click on that. And if this isn't appearing for you, or you're having any other Zoom issues that we can't answer for you, if you go to the confirmation email or the reminder email sent by Zoom when you first registered and then sent again this morning, there are some helpful tips and links at the bottom of that email. So as everyone on their computer has already seen, we are using the chat box to introduce ourselves. So if you haven't already, if you could type in your name and organization so that we know who all is on the call. Another great way to make sure we know who is here is to rename yourself. And you can do this by right-clicking on your video, and it'll give you the option to rename. Or you can go, if you hover over your video or your name, you can see there's 3 little dots in the upper right-hand corner. And if you click on that, that's another way to rename. Again, your name and organization would be helpful for the conversation. So lastly, just a reminder for everyone to try our best to keep our conversation related to oral health access. So I think with that, I will pass it over to Helen to get us started with some content.
All right, good morning, everybody. It's great to see everyone joining the call. I know we still have a handful of people coming on. This is, as Amy mentioned, our 4th session for Stakeholder Sharing Sessions, and we're trying to do our best to continue to engage with all of our stakeholders in place of what would normally be live in-person meetings. So I really appreciate everyone taking the time during a time that is very Zoom heavy right now to coming in and spending some of your day with us. So as you can see, we're going to talk a little bit about oral health access, and I want to give just a little bit of a background. I know many of you have joined some of our other sessions, or you're very familiar with our work, but I promise we'll just take about 2 minutes just to give a quick update for those who may not be as familiar. Our State Oral Health Coalition is a statewide network. We've got about On any given day, anywhere from 800 to 1,000 stakeholders, individuals, and organizations that we work with. A lot of our work goes into connecting organizations and individuals that are working on initiatives. So we do a ton of communication, and we also love to convene people to, do some really thoughtful thinking around solutions to the problems we have in our state. We work as a implementer of programs for the Department of Health's oral health program. So we manage the implementation of their CDC and HRSA federal grants, which allows us to work directly with programs in the state. We are a nonprofit. We've got a small staff of 3 full-time staff that all work remotely. And we really do our best work when we get partnership and buy-in from all of our stakeholders. So doing things like joining these calls, giving your opinions, providing new resources for us to share. Those are all things that we really encourage everyone to do, and that helps us do a better job in our work. Wanted to just take a second and look at our main priorities that we focus on as a coalition. One of the, we've determined these a few years back, and we continue to do work that forwards the progress on these 4 things. One is, of course, looking at Pennsylvania oral workforce, which includes not just dental providers, but, also members of the community that can provide oral health education, or, other healthcare providers like pediatricians who might be able to provide oral health services as well. Our second priority area is community water fluoridation, which our state lags behind, the national goals in the individuals that receive optimally fluoridated water. So we work with not just consumers and community organizations on this, but also groups like water operators and water associations to really advocate for drinking optimally fluoridated tap water. And improving oral health for Pennsylvania's most vulnerable populations is our third priority, and that we're going to touch on a little bit of that today because we know that certain populations in the state struggle, whether it's geographically or whether it's because of, being part of an underserved community or, ethnic and racial minorities. Poverty weighs into that pretty considerably. So there are a lot of different reasons we would consider someone to be part of a vulnerable population. And so really kind of promoting that health equity focus and lifting those individuals up to get better care is a big focus for us. And then lastly, we wouldn't be a proper coalition if we didn't advocate for policy and oral health policy in a lot of different ways. So that's working with the different departments in the state. It's also working with individual organizations. So we serve on a ton of committees and different groups where we try to put oral health into the conversation, no matter what that conversation is. So if you want to learn more about the coalition work, I encourage you to sign up for our newsletters and check out our YouTube channel so that you're able to look back at some of the videos and meetings we've had in the past, and it can give you a good idea of the programming that we've been working on. With that being said, our main focus du jour is we wanted to talk a little bit about access. And it's interesting. So the word access is kind of a buzzword right now and has been, I think, for a few years. And I, sort of in preparing for today's conversation, I was sort of looking at some different resources around that. And what I was finding was this discussion around, are we talking about access or are we talking about barriers? And does that mean the same thing? So I just want to sort of frame what I'm going to say with that, as it might be just some way to get, your creative juices flowing for conversation later. I have on the slide here a bunch of different little graphics. The upper left-hand graphic is a map that might be very familiar to some of you. That is the colored areas and the colored dots show the dental health professional shortage areas that exist in our state as of fall of 2019. So those are places where we have basically a ratio of more than 5,000 to 1 population to dentist provider. And so that's a really big issue for us because we know those areas even if all else is equal, there may not even be a provider to see individuals living in those areas. And when they do the calculations, they have figured out that nearly 2 million of our residents live or reside in one of those areas. So that's a lot of people that may not have proper access to dental care. When they have crunched numbers more specifically on that, the latest stats showed that we would need 277 new dentists to come into the state and to practice in those specific areas to meet the exact needs of where we need dental care. Again, that probably means we need an influx of about 2,000 dentists if we want to have 277 of them show up in those areas. But that's what they sort of look at from a federal level from the Health Resources and Services Administration. The bottom map just was something that we worked on. Many of you work with populations that are served by Medicaid, and our Medicaid we have a list of about 3,000 dentists that are cited as Medicaid providers in our state. What we did last year was we took those, and anybody that was sort of a duplicate location, we've pinpointed them down to just the location, because you may have 35 dentists that are credentialed at one location, but only 2 of them practice there regularly. So we really wanted to see, what does the map look like if we only look at location, not total number of providers? And so that's what you're seeing there. It's 1,037 locations across the state where there's a Medicaid provider practicing, is the best we can call that. And the circle is really to draw your attention. That's just one sort of desert area in the state. And I'm going to show off my math skills here. I actually had to write this down in my notes because this wasn't going to happen. But I had to go back to my, 9th grade math or something to figure out square miles and how much that really is there. So when we look at location to location distance, we're about 40 miles in between those 2 locations. So if we do our area of a circle equals pi times radius, squared, that really was difficult for me. That little circle that stretches about 40 miles across in Northwest PA means that we have 1,256 square miles of the state right there that have no access to a Medicaid location. So that is one of the things that we really have to sort of take into account when we look at these maps. That's a pretty big area to have not one single Medicaid dental provider. And again, we could draw those circles all over the place, and this isn't even taking into account whether these practices are taking new patients or participating in all the insurances or anything like that. So just sort of I thought a little bit of an insightful look, and I got to show off some math skills. So when we're looking at, what is our definition of access, these are things that many of you have had conversations with us about, or many of you are focusing on in your own work. So I probably don't need to go into too much detail. But, looking at, yes, we have a dental provider shortage. Yes, we know that they are geographically not distributed equally. And then, the things I just mentioned is, are they participating in Medicaid? We know that, statewide, only 23% of our dentists participate in Medicaid for general dentists. So, and if they do participate in Medicaid, maybe they only participate with one MCO and not all 4 or 5 that are in their zone. And then, for those that might be participating and might be willing and able to see patients, are they accepting new patients? Do they see patients with special needs? Do they see extremely young patients? These are all factors that really do put up those barriers to care. And then oral health literacy, we can offer services, and if services are available to families, are they really seeking them? Do they know that they're available? Do they know why they should be seeking them? So those are pieces that compound the problem. And then I just put a little bit of information here when we're looking at, our vulnerable and underserved populations. They're relying on our safety net clinics, places where you might not have a private practice provider, but you're able to seek care. Maybe you're uninsured. Maybe you need a practice like a federally qualified health center with a sliding fee scale. Those are different things that we've really got to look at and analyze a little more closely. Rural versus urban, I think that was pretty obvious on the previous slide with our mapping. And then, you know, also looking at income levels. We know that individuals and families that make lower income seek dental care less or have less access, and also end up with higher disease rates as well. And so all of that ties into the health equity model of how do we elevate those who need the care the most into those positions. So what we're going to be doing, and again, I promised I would only talk for a few minutes, so I did want to give everyone a little bit of an update. Things have, of course, gone sideways in light of the COVID-19 pandemic, as I know many of you are in the same situation with your work and your work efforts. But we do have a couple projects that we're working towards this year, and I wanted to let you guys know so that if there's something you want more information about or that you want to help with, you know, we can certainly connect after the call. One of our newest things that we're trying to figure out is, from an access standpoint, we've heard anecdotally from many providers, both dentists and hygienists in the state, that they're maybe leaving practice permanently in light of COVID-19. You know, whether it's just too much of an economic burden to be, you know, not open for a length of time because of the illness, or whether, you know, maybe they were already close to retirement age and this was just sort of the tipping point to push them over. So we've developed a survey we're going to be sending out to all of the dentists in the state. And I did put the link in there, but it's still being finalized. So, but I wanted, you know, if anybody wants to check it out, you guys can be first to check it out. We're going to hopefully get that out in the next week to all of the dentists in the state via mail and electronic means, by electronic means, so that we can get an idea of who's not coming back and where are we going to be in 6 months or a year from now in terms of those provider shortage areas. Our teledentistry projects continue. We've got funding under our federal HRSA grant right now, and we've got a program running up in Northwest PA with Erie County Department of Health and the local Head Start groups there. And we've also seen, and we'll talk a little bit about this later, we've seen some increase in teledentistry as a result of COVID-19 as well. Looking at our Medicaid data for 2019, our last big data pull from the state was 2017. So we're going to be getting those numbers from the state so that we can look at a county level, you know, what services are being provided. And compare that to the number of providers in those counties so we can see, really get a better picture of where we're at. Our workforce survey, when, you know, we're talking about the workforce survey, our state collects workforce data every other year when the licenses are up for renewal for dental providers. And we've had a pretty long wait for those data historically. But I wanted to just let everyone know that the Department of Health is working on improving that. So we're hopeful, as of right now, the 2015 data are the last data we have. So we'd like to get some more recent information, especially in light of the COVID changes. PCOH has a charitable work tracking survey. So we know that, you know, items that are billed to insurance are one thing, and direct reports of services provided by, you know, dentists and hygienists is another, but we really want to keep track of how many free and charitable services are being done. So we did a 2018 survey, and we are in the process of finalizing our 2019 data collection survey, which will be ready in the coming weeks. Our new state oral health plan will be published this summer. It's going to be a 10-year oral health plan. And we have the very first priority in that plan is access, prevention, and education. So it's something our state's looking very seriously at, and we have 13 measurable outcomes that we will be measuring on an annual basis as part of that plan. Our Dental Access Project is a project funded by the Highmark Foundation, where we're doing an environmental scan of the state, and we're seeing where our issues are and where people look for dental care. So we're working with United Way of Pennsylvania and 211 on that. So that report should be out sometime late summer, maybe. And then lastly, we continue to advocate for the expansion of adult dental services covered under Medicaid. That really is a big deal, a big part of our work. And so we're building those relationships with legislators and also gathering partners to help support us in that work. If anybody finds that to be a key focus area in their work and their sort of area of interest, please let us know. We do hold monthly calls, and anybody is welcome to join those if you want to sort of stay apprised of that work. So lastly, before I turn it over to our invited presenters to share some information, I just wanted to give you guys a little bit of, what I'm calling food for thought. I was going to put an ice cream cone on this slide, but then I thought it wouldn't be appropriate. Just some thoughts to think about. Do we have adequate providers in our state? And I would love to hear the perspective. I mean, the point of this call is we're going to share some information, but we also really want everyone on the call to participate and tell us a little bit about your concerns or your successes, especially your successes. We love hearing that. So, if these questions sort of help you to think about, what kind of things are important to me? What are the biggest issues that we're having in our own organizations? Is it we have plenty of dental providers, but we just don't have any specialists, or, we just don't have enough providers participating with insurance in our area? Or is it the transportation? County level Medicaid transportation is a big deal. County level public transportation is a big deal for a lot of areas. Is dental fear a problem in your area or with the communities that you work in? We're unfortunately seeing a little bit, I think, of an uptick in that right now because of the uncertainty around the pandemic. So that's going to be something we need to address very closely with our residents. And then stigma. We still have a situation with for those who work with parents of young children, there's still a certain stigma of, parents not wanting to be talked down to or scolded for their child having problems. And so, that's another barrier for us to think about and talk about. And then I mentioned earlier, of course, oral health literacy. What knowledge can we give to individuals who are seeking oral health care? So those are just some sort of high-level thoughts that, I wanted to sort of share as the areas that we tend to get the most involvement in. And if anybody wants to sort of share any thoughts or feelings on that, when we open up for discussion, please do. And you can also type things into the chat box too if you're not comfortable speaking live. That's fine as well. So with that, I'm going to ask Jenny Englert from Family First Health, who is our former board chair and oral health advocate extraordinaire, to talk a little bit about what Family First Health has been doing right now and sort of looking towards the future for dental care in York County.
Thanks, Helen, and for inviting me into this conversation today. It actually gave me a great excuse to pause and really think about all the work that we've been doing under this COVID frame recently. And as I close, I'll tell you where it was really a positive for me to pause and have that time to think. Family First Health is a federally qualified health center. We are kind of rooted in York County and the city of York in particular, but have sites across 4 counties, York, Adams, Lancaster, and Lebanon counties with 7 sites of care. We've been in existence for 50 years, celebrating that anniversary this year. And for the past 15, while we had offered oral health and dental services far beyond that, but for the past 15 years, there's been a real concerted effort in our organization to address access issues, oral health access issues. And we've addressed that through expanding fixed sites of care, and through expanding our mobile services. So going into schools and early childhood learning environments, including Head Starts across our region, and have been building that program for almost the last 10 years. So to the point that last year we were able to touch 4,000 children in their learning environments with screening and preventative services, allowing us to identify those children who had greatest needs and bring them into care or connect with their dentist of record, or take care of full preventative needs in the school setting, which has been a real asset in our community. We, in total, have about 8,000 active dental patients across our service area, seeing us in our fixed sites. And all of that being said, and all of that effort and energy and engagement and expansion that we've undertaken specifically to promote the idea that oral health is integral to good overall health, access continues to be a challenge in parts of our service area. So I want to reiterate the things that Helen already articulated that exist across the state. We certainly don't have the answers to all of those. We think we've been fairly creative in some of our solutions, but as we continue to watch the data, we know that about on average across our service area, about 20% of Medicaid eligible folks are still not receiving regular dental care. Now that is a significant decrease over the past decade, and so we're proud of that, but we also want to acknowledge that there's certainly still work to do. That being said, how we do that work at this point in time is really a particular challenge, and I'm not going to sugarcoat any of that. That might not be the right way to talk about that with this group, but I really struggled as I was preparing for today, because internally we are having lots of conversations about the mixed messages that are being sent about the importance of dental care and access. We have historically prioritized safety across our organization, and with a particular emphasis in our dental department. Our dental providers and teams undertake risk every day in the services that they provide, and that's why PPE, training have been important historically within our office. Certainly within the first few weeks of the pandemic, we understood the directives from Department of Health, CDC, and others. We have a growing intolerance to the messaging that dental is somehow not an essential health service. And I'm just going to be very clear about that's the feeling that we are getting based on the messages at this point. It's going to be very difficult to re-engage with our patients who we have instilled in them a knowledge that getting preventative care is vitally important to their overall health. Following through on treatment plans is vitally important. And yet, at a time where caring for our health in many ways should be top of mind for all of us, and certainly doing that in a safe way, we're being sidelined in the delivery of dental care. I'm not going to stay on that soapbox for very long, but it's something that I felt was important to share today. We're concerned about the future of our dental workforce. We're concerned about the messages that folks in training and folks newer to the profession are getting about how practice will be in the state of Pennsylvania and how supported people will be in the state of Pennsylvania. We hope that we can continue this conversation. Access issues will grow as a result of demand will grow, issues will continue to evolve, and so access will continue to be impacted as we move through the other side of this pandemic. And again, I want to couch everything I've said with certainly an understanding of the importance of safety and prioritizing that in our offices. But we believe, as the CDC has started to evolve their thinking about the importance of reopening access to dental services, that we in Pennsylvania should be able to follow suit with that evolving guidance and really work from the history that we understand, which is there are many ways that we mitigate our risk of transmission of a variety of things in our offices on an ongoing basis. I'd appreciate any comments that others have about that as we move ahead, and again, didn't want to divert our conversation today, but really wanted to, in leading into my third point, which is our work is going to get actually more challenging as we move ahead in addressing access. We're going to have to re-engage with our patients about the important messages that we've taken, in some cases, years to develop, and relationships that have taken years to evolve. We are, and this is where it was a positive reframing for me to prepare these comments for today, there is a lot that we can do, even under our current restrictions. And as we think about access, we need to build our muscles in all kinds of areas of access. Everything from the practice of teledentistry and using video as well. We've learned those skills within our offices and actually have found them very valuable. I think in some ways, more valuable than we would have perceived that they were prior to COVID. So that we've gotten to experiment in that space is one of the elements of silver lining of this pandemic that we are grateful for. And we know that our patients are benefiting from. We are outreaching to patients that were mid-treatment plan and engaging them in the importance of continuing to evaluate their progress, to working with our youngest patients and sending messages from the Tooth Fairy to keep them and their families engaged in self-care at home. Which is the most important thing that I not only am preaching to my own 14-year-old, but that we're sharing with our patients, that this is a time to double down on self-care and something that we all can take part of. But those are the messages that are important to come from into many families from their dental provider and re-emphasize that work. So there's much that we can do. And I think for those that I've gotten to know through PCOH, one of the important steps will be continue to be strong advocates as we move forward, not only in our current situation, but as we reframe many elements of our delivery, integration, the telehealth components, and just continuing to engage and understanding now more so than ever the need to elevate the profession, the practice of dentistry, and going back to our core historic message, which is oral health is integral to good overall health. And if that is not embraced from every element or every stakeholder and decision maker, most importantly, I think we've seen play out in this pandemic, we will continue to stumble as we move ahead. So I look forward to continuing to work with all of you. I know that all of you are developing highly creative ways to continue to engage your patients, for those of you that are delivery providers, or continuing to advocate or engage with whatever segment of the population that you're working with. We'll need to work collectively to re-engage around maintaining access and then identifying where we're going to see new gaps. We know that, or it's estimated that between 10 and 30% of people who are currently commercially insured will lose that insurance post the pandemic. And so we will have emerging vulnerable populations, and that's just one indicator of that. And as we all know, historically, oral health care or access or engagement with the dentist is sometimes the first thing to go as families become more economically challenged. So we're concerned about our historic population, and we're also concerned about how to meet the needs of emerging vulnerable populations. And I look forward to having that conversation with PCOH as that continues to evolve, because we will see new populations that will find themselves in greater need. Don't have any answers about what anything looks like. I know Kelly has great things to share with you as well, but really just wanted to take this opportunity as a provider who's in this struggle of figuring these things out for all of the services that we provide as a federally qualified health center. I chose to just be really honest with all of you today, and look forward to working with you to resolve the problems in the short term and the long term, and develop creative solutions, which I know this group is so adept at doing. So thanks for the time today on the agenda, and glad to engage in dialogue or questions as we move ahead.
Thank you, Jenny. Thank you. Any immediate questions for Jenny before we're going to have Kelly Braun from the Office of Rural Health speak for a few minutes before we do our main conversation. But if there's anything that anyone wants to sort of address to Jenny now, that's fine. Okay, there will be more time. Kelly, would you like to give us a little bit of a rural update, maybe?
Sure. First, I have to say I love the letters from the Tooth Fairy idea. I actually wrote that down, and I may pass that along and reuse that in rural Pennsylvania. So I think that's a great way to keep patients engaged. So I know many of you, there are some unfamiliar names here. So just a little bit of background for you all. My name is Kelly Braun. I work for the Pennsylvania Office of Rural Health. We are one of 50 state offices of rural health, and we are actually based in the center of the state, usually on the campus of Penn State's University Park campus. So my role with the office is oral health programming and oral health programming specifically for rural populations. So about 4 years ago, we partnered with the DentaQuest Institute at the time, now the DentaQuest Partnership, to bring this program called More Care to Pennsylvania. And More Care stands for Medical Oral Expanded Care. And the idea was integrating oral health into medical offices, particularly medical offices that are rural. So we have, like Jenny mentioned, the FQHC designation. We also have rural health clinics, or an RHC designation in the state. And currently there are about 70 rural health clinics across rural Pennsylvania, where Helen had sort of done her circle and her map, or her math earlier on the map. That is one of the areas that we serve. A lot of our rural health clinics are located in those areas where there weren't a whole lot of teeth on that map. And so rural health clinics, their role is to provide primary care. So they are there to provide primary medical care services close to home for patients, so that they're not having to travel across the 1,000 whatever square miles it was within that circle to find that access to care. So our idea, and actually it was really DentaQuest's idea that we implemented, was to start to incorporate oral health into those areas so that patients could first learn about the importance of oral health to their overall health. As Helen mentioned earlier, health literacy is a big piece of this, and so we have to educate patients so that they understand why their teeth are important. And then also to teach a little bit about home care, and that self-management, which, as Jenny said, is more important now than ever, to be maintaining that oral health at home. And then we also taught medical providers to put fluoride varnish on patients' teeth, and then to make this referral to a dental office. So dental offices might be 40 miles away, but if if the medical provider is referring them, patients tend to be more likely to get there. And oftentimes the medical providers were helping to ensure that those barriers were as few as possible to enable the patient to get there. So unfortunately, I haven't been able to visit the rural health clinics like I usually do. This whole being home since March is really strange to me, I have to say. I'm sure as to many of you as well, but I'm used to going out and visiting these clinics and interacting with the providers, and I've not been able to do that. I do still hear from them, engage with them electronically, virtually, and we actually have been collecting data every month. So since we started this project, the clinics will actually report back to me each month with how many children, which is generally in most cases our primary focus, although a lot of these clinics have started to expand this integration to all of their patients. But we look at how many children we're seeing for well child visits, and then of those children that we're seeing, how many had an oral health risk assessment completed? How many had oral health self-management goals reviewed? How many had fluoride varnish? How many were referred out to a dentist? How many of those that were referred to a dentist actually went and saw the dentist and we got a referral back, or a treatment report back from that dentist? So we're looking at all of this, and honestly, I sort of expected in March, like, well, I'm probably not going to get any data for March, maybe half of March, probably not the end of March, probably not getting anything for April, and now, May, maybe not. But I actually have been continuing to get data from all 13 of the clinics that are engaged in this project and have been for the past several years. While their patient numbers are a little bit lower, which we would expect, people have been encouraged to stay home, they are still seeing some children. I would assume that most of those visits probably were not well visits. They were probably coming in for a problem or another condition, but oral health was still being incorporated. So the medical providers are still having these conversations. They may not be putting fluoride varnish on anymore, but they are still having conversations around oral health risk. They're still having conversations about why it's important to brush at home. And I really do think, as Jenny mentioned, we've sort of spent all of this time discussing why oral health is important and showing and trying to, help patients understand that it really is a necessary treatment. And now all of a sudden, as we've, essential, non-essential, and we've started labeling businesses and things, dental sort of has become non-essential. And I think it is going to be an uphill battle to help with that messaging, but I really feel like our medical providers can help. They can help patients understand, again, why it's so important. I think hearing these messages from the medical providers, who are often the first person that patient will see, that's the most convenient area. They might even be, unfortunately, we try to avoid this, but they might even be showing up to the emergency department with oral health concerns. If we can educate those providers to teach the patient the importance of oral health and teach them that it doesn't have to be scary. You don't have to be fearful to go back to the dentist. Educating them that the dentists are well prepared with their PPEs. Their main goal is keeping everybody healthy, the patients, the staff, everybody in that office healthy. I really think that the medical personnel can continue to help with these, with the messaging and with getting patients back into the dental office, especially for preventive treatment when that time comes. I think that two of the barriers that Helen mentioned, so transportation could be tricky, especially the public, county transportation. We have to take another look at that and figure out how do we continue to offer this in this post-COVID time, or when we get to the post-COVID time. And then fear. I've seen a lot of dental offices actually putting out notices about this to patients. When you go into a dental office now, those providers might look a little bit different. And if you already sort of didn't really like going to the dentist, found it to be a little bit fear-inducing, it's probably going to be much more fear-inducing now with all of the extra PPE. And so really explaining that to patients, and again, getting the medical providers to help patients understand this is what they're going to look like and here's why. I think that'll be super important moving forward. So just a little bit about our program. I'm happy to hear, again, thoughts. I'm happy to hear if you guys are incorporating these types of programs in your offices. And I'll stop and let the conversation, the group conversation, begin at this point.
Yeah, so thank you, Kelly, very much. I do want to sort of just open it up now if anyone has anything that just insights on the conversation so far, or what they would want to share. You can unmute yourself. We promise we won't mute you unless we hear a lot of background noise.
Hi, this is Nora, dental hygienist with UPMC for you. I'd like to kind of just give some more positive information based on what you two are saying. It kind of goes right along since we've all been stay at home, can't go anywhere. We've been doing mostly just telephonic outreach. And yes, there's a lot of fear of going back to the dentist has been, and so helping families navigate through that and educating them on what, like you said, Kelly, what to expect seems to be a lot of what we're doing. And transportation is a concern because even getting on public buses now, there's only limited amount of seats available. And how does a family even get to the dentist? So yeah, it's been interesting to really hear so much more, and they're so families are really appreciative that somebody's reaching out and giving them some more oral health tips and talking about, I keep saying preventative at home is still key no matter where we are with this, that families have a big stake in it, that they can do a lot just from home and taking care of their children's teeth. So that's what we've been up to. It's great to talk to families that way, and encouraging them to continue to keep a dental home is also something we've been talking with them on the phone with, and how important that is. Like you were saying, Jenny, we don't want to lose these families, especially from the fear of just going to the dentist now. So yeah, that's been our talking points as PhDHPs with the health plan.
Thank you, Nora. That's great. And we were able to co-brand a document that's sort of geared towards patients. It's available on our COVID page on our website. That's just sort of helping to prep the patients to understand that things may look a little different when they return to the dental office, and whether that's temporary or not, we're not really sure yet. But, at least they give them an idea so that they're not overwhelmed, by having, their temperature taken in the parking lot. That we just are trying to make sure that we're prepping everybody. I did want to share just so that I did hear, and I'm not sure if I'm supposed to share this yet or not, but I did hear that the Department of Human Services that oversees the Medicaid program is looking into putting out some information very, very soon about allowing, even fluoride varnish application at home. So we might see that come up in the coming weeks, where parents could pick up some applications like drive-by dentistry there, and then they could be walked through that at home. So just sort of I know Eve's going to be smiling about this one because she's been trying to get parents to apply fluoride varnish for years. So I don't know, you know, it's not official yet, but.
But we're going to work on first getting folks to do the teaching about brushing and oral health care and getting to the dentist first. That's more important.
Absolutely. Absolutely. So any thoughts? I know we have some folks on the phone. I'm just looking to see. I know we've got some university folks. We've got some free clinics. We've got some child care or early child learning. You know, I know, you know, we've got providers and provider orgs. So any thoughts on anything that's been mentioned so far or any new ideas? I know that for those who haven't heard, for the groups that work with Head Start families temporarily, we hope that they have sort of postponed any toothbrushing at the Head Start facilities and the child care centers. So because now for Pennsylvania, we're starting to open probably some up at some point, but you know, the ones in Pennsylvania did close, so that didn't really affect our centers as much, but in states where they did have Head Start facilities staying open, they did postpone all brushing just because of the risk of transmission from aerosols and toothbrushing. So again, another mountain we're gonna have to climb back over. You know, as we come through this. Has anyone heard anything more transportation-wise from the folks in their communities? Because that's something that I haven't gotten. I haven't heard. I know, as Nora said, we've got the issues, especially in the more urban areas. For folks that rely on public transportation for daily use. You know, I really hadn't thought a whole lot about that. But I know a lot of the groups that run the Medicaid transportation, you know, the small buses that take folks to their medical appointments and things haven't been back up and running yet either. So I don't know if anybody's heard anything.
I haven't heard anything about it, but I did have a thought the other day when I was looking at the guidance that we put out in conjunction with Department of Health about some of the things people can expect when they're able to go back to the dentist. And one of the things is you may be asked to wait in your car. And this holds true for, you know, any kind of appointment. How does that address the people that use public transportation?
Marilyn, I can't say for sure with people that take public transportation, but some offices may need to consider having a waiting place outside of their office. Where I'm currently working at a center for individuals with disabilities, people who do take the bus would have the ability to come in under a covered area and wait until we call them. But our plan is to have them wait in the car and then call when we're ready for them to be able to come up. So that's the kind of thing I think a lot of offices are going to have to think creatively and really get outside of their usual thought process, maybe even have one of those pop-up kind of tent things with some chairs outside if they need to, if they have a lot of people that do transport that way. You know, I think it's just a matter of creativity there. One of the questions I had for you, Jen, and it just went out of my head because I have COVID brain now because I've been home so much and only going in for emergencies, and all I do is read COVID, 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 COVID. Let me think a second. Oh, yes. Are you guys looking at any kind of an air purification, like a filter UV kind of thing for your health centers? We're thinking about those for the individual treatment rooms, not the big isolation, et cetera, but just the air filtration systems that will catch a certain amount and UV? And if you are, how are you conveying that information to patients or facilities that you work with to say, hey, we have this going on to help keep the room, in addition to all the usual precautions we follow, which are tremendous, we've also added this extra benefit of, making sure the air has been purified.
So, we've looked into that. We certainly explored negative airflow and decided that that wasn't actually appropriate or cost effective in the types of services that we were seeing. I'm not saying that we've made a final decision around kind of air filtration, but again, in our initial looks, the protection that it's offering is so minimal, it's actually probably better for our employees' just ongoing health outside of COVID as reasons to think about air filtration for pollen and all kinds of other things. And so again, is that the priority? What we really have chosen to emphasize is the use of PPE, which has always been a priority for us, and patients are really used to seeing us in our dental services gowned, masked, face shields. So there'll be the change to the N95, which our patients probably won't notice the difference. But really little changes to PPE, some changes to the frequency in which we're changing that, those kinds of things. But what I would really encourage folks, and maybe Kelly, this is something in your project that could develop some partnerships around, those folks that are providing medical care have stepped through all of these issues already. So our federally qualified health centers, our rural health clinics that are doing medical care as well. We've thought about how to enter people into the building. We've thought about how we're doing screening. So there really is, and not that will all transfer seamlessly into dental operations, but is a great jumping off point. And I feel like there's some opportunity for shared learning. So that we're not reinventing the wheel as we're reopening dental offices and thinking that we need to start from scratch if those aren't offices that are affiliated with medical providers. So I just had that thought when people are kind of listing off their checklist. These are things that we were thinking about early in the pandemic because like most primary care providers, we needed to find ways to stay open for certain types of visits and certain situations that our patients had. So I would just think there's maybe some learning and that could make the process and pacing quicker for dental reopening than the starts and stops we had in medical and the things that didn't work. That list is probably as important as those things that did work in the end to try. And then to recognize, just the last thing I wanted to share, a message that we've been clear with our patients from the beginning around is there will be changes in information. There will be changes in the way that that we present and the processes that we have you walk through to address safety. And that really is due to the nature of a novel virus and a pandemic. And these are things that none of us have lived through before, fortunately. And so I think setting that baseline both for staff and for patients has been hugely important because there are trust factors at play, and ways that we can either build trust at this point or degrade trust that may have existed. And already there's rumors in communities about the origins of the virus and the numbers and the red, yellow, green perspective. And we really want to try to be a source of truth for our patients and communities. And part of being that source of truth is being really transparent about that messages are going to change. We're going to learn new information. And that's the nature of managing through a pandemic. But I would just encourage you to take a moment to think for all the folks that you interact with that you are a trusted source of truth and leverage that at this point in time. It's going to be really important. People are being bombarded with messages that may be inconsistent with what's best for their health. But that's not going to be apparent unless a trusted source is giving them information as well. In a gap of information, people will go to where they can find it. So we need to be flooding people with information at this point in time from us so that they will benefit from that and continue to engage with us.
Thank you. And that sort of ties into, I had shared on another call, but I think it's helpful information for those who are working directly with communities, is that Pennsylvania for the first time this year has a certification program for community health workers. And so I think that as we're talking about how we communicate with communities, that's a lot of communicate with communities by using community health workers. That we want to make sure we did submit a formal ask to the PA Certification Board to include oral health into their curriculum as a required hours amount. And so I'm very, very hopeful. I had a great call with their executive director, and I think that we will see those formal guidelines come out with a requirement for that. And so there's opportunity there where, especially for those of you who are providing direct services, to be able to work with community health workers. So far in the state, I believe we only have 40 that have undergone the official certification process, and 75% of those are in South Central PA. But I expect that number will go up considerably over the next year or two, and when formal education institutions develop programs. So, right now it's just a grandfathering year so that people can get their certification who've already been working in the field. But that's something that might be great, I think, even from the insurance perspective, to work with community health workers, as part of their staffing and process. And even, within the free clinics and the FQHCs and the RHCs, it's a great place to really get that communication flowing and improve the oral health literacy. Is anyone working with the CHW now? Okay. Figured I'd check, because I know we have some. As I said, they're just starting to kind of roll through the state. Any other thoughts around some of that messaging ideas? Is there anything that you all would like to see our coalition work on? I keep saying we've replaced a lot of the work that we were going to do. So, as we looked at 2020, we had a whole lot of programs and things that were all set in place and all ready to go. And now, goodbye, they're gone. At least temporarily. So, we are doing some other things, and I don't want to, digress into a bunch of other topics, or Amy and Mary Lynn will yell. But, it is something that, we're working on sort of spinning some things in a different direction. So, if there's any needs that you've seen in your communities that we can sort of help to fill, or resources that we can help develop, that really is just such an important part of the work that we do. I know we're going to be sending out information. The state has approved dental providers to be licensed tobacco cessation counselors. Shouldn't say licensed, should say certified. And so we're going to be sending out, we've put some of our information up on social media already today. We're going to be sending out to all the managed care organizations to share with their provider networks, since tobacco cessation counseling can be done and paid for through Medicaid now. We would like to get as many providers trained to do that properly as soon as possible. So we're having a live webinar the first week of June that will be recorded and housed on our webinar portal after that. Any discussion on that, the tobacco cessation piece? So I think that that's interesting in terms of a medical dental integration. Dana, did
Helen,
you want to say something?
Yeah, because I had been talking with Paula DeGregory about this, and she had mentioned that. And am I right that it'll be a two-part? So there'll be an online part and then a live part to the training, correct?
Yeah, so it's doing a self-study webinar and then a live webinar. So, because nothing's in person, of course, at this point. We had original plans for that. Right. But yeah, So the initial first part, which is the every smoker, every time piece, can be done at your own pace whenever you would like. And then the second part, which is the part that's geared more towards dental providers, then that would be offered on June 2nd.
Yeah.
And then we'll have it housed probably about a week later. We'll have it up on the webinar portal. So it could essentially be, you know, self-study for both if needed.
Perfect. Great. Thanks.
Yeah, absolutely. And it'll walk everybody through how to get the, you know, credentialing and everything that they need. So I think it's a great role for those who work more on the prevention side as well. So, you know, if you have hygienists who maybe aren't going back to full clinical care at this point, that could be a role that I think they would fit well into as well.
And while they're doing their tobacco cessation, they could potentially touch on those home care things as you have the engagement of the patient to then, you know, A, get them to come back, but B, keep them healthy and, you know, for the time being.
So this is Jess from UPMC. I'm super sorry that I could not figure out how to unmute myself, but the magic person on the other end of this fixed it for me. So I wanted to just touch base on some of the information that we're kind of looking at as a managed care plan. And one of them being that families, while we can take away all the barriers for the providers and getting people to come through the doors, we're really going to still have a huge issue with our patients and families being able to navigate the social determinants of health that are keeping them from coming into the practice environment. One of those that was brought up yesterday and is something, you know, that's kind of comes first of mind to myself is that it's a one parent to one child or one caregiver to one child arrangement for all appointments. So even if families want to participate in care, being able to find a trusted caregiver for their other children while they're out of the home can be very, very challenging. That's in addition to trying to navigate the transportation and trying to navigate, you know, masking your child when they have to go into an appointment. So we're really trying to think of different ways that we can perhaps bring the services to our patients in their home environment or in their community, opposed to having them come to services. So that availability of having that extra support is a little bit more organically done, or mom can keep an eye on her other children from a distance, opposed to needing to travel on multiple buses or travel into an office setting. One of the things that we're moving forward with on the dental end of things for our children who are attached to a dental home, and we're defining that as having had services in the past 9 months, is that we're going to be offering to our membership and our dental community the ability to do a preventive visit for children via teledentistry. So that will be composed of a educational session with a provider to go over toothbrushing and flossing, getting images of the oral cavity of the teeth and of the gums in the mouth, and a discussion and visit with the dentist via teledentistry to make sure that we're seeing all of our children attached to dental homes. We don't lose that relationship between the provider and the patient, and that we're able to still get a look in the mouth so that any major crises can be averted, or a child can get brought in for restorative care immediately or whatever they need. And if there's SDF issues that could be, or I'm sorry, issues that SDF could address, that they would be able to perhaps get that or another non-aerosol producing type of treatment that may help ward off any furtherance of an issue. We're hopeful that we'll be able to roll this out soon, and Avisus will be notifying our provider network of this information shortly. And I'm hoping this is a good bridge to being able to keep the relationship open and help meet families where they are during this difficult moment of time. I call it a moment because I really hope that's what it is. I also think this may help providers with the PPE issues that we're experiencing right now, being that the cost of PPE is so high due to supply and demand, that by the time their next visit would come around, they would be able to go into the office And the overhead for providers would be a little bit less significant if they do have to don the full PPE per the CDC guidance. So that's kind of my little spiel. I don't know if anybody has any questions, and I'm very sorry it took me so long to figure out the unmuting piece. But thanks again to the magic person behind the scenes that helped me.
That would be Amy.
Thanks, Amy.
Jess, this is Mary Lynn. I love that patient-centered idea that you have. My question is, how or does that impact on reimbursement when you deliver services outside of your clinical facility? Can you still bill and receive payment?
We have set it up to bill and receive payment. It will not be, obviously they can't do a pro fee, but we'll still be doing a preventive exam, and we will be using D9994, which is a dental case management enhanced education code, which will be reimbursed to kind of offset. It's not the same as a pro, but it's to act in place of that. That's really the focus around education, and then using the 9995, which is the synchronous teledentistry code, so that providers will be able to leverage that just to let us know that this was a teledentistry encounter. Now, my rationale for that is in 6 months, or a year, or whenever this ends, if we have to go back and look at a patient's history, we need to know when they were physically seen in a practice environment, when something physically took place, versus when something happened in a teledentistry capacity. Those are slightly different, so we didn't want to use the same coding sets in totality for this versus what you would get in a brick and mortar or in a community setting.
Well, and Medicaid or the ADA has developed some teledentistry coding to use rather than the standard CDT coding. That's what we've been using to keep track. They have developed those codes so you can, search to hopefully get the right information when you're searching your
Correct, and that's the 9995, and then on top of that, they opened, at least in Pennsylvania, they opened the limited oral exam, the DO-140, and allowed all clinicians to triage patients for urgent or emergent care and then to bring them into the practice environment. This is just taking it a step further and saying, okay, you're a well patient, but we still want to see you and we want to make this work. So the patient doesn't have to be calling with a complaint of pain or, swelling or anything like that. This can be, I called a mom today. She said she's uncomfortable bringing her child in because she's unsure about COVID. I can offer this as an alternative. Or mom says she'd love to bring the kids in, but she has 5 of them, and this scenario is not going to work well for her.
So that's interesting. I'm glad to hear, and I actually, one of the things I think that I'm so thankful for about this is we've gotten so much flexibility from insurances and from facilities, and like everybody has sort of stepped up. So I think that would hopefully be a long-term side effect, that, we will have a little bit more flexibility in how we provide care and how we get people educated and doing things. So the only other question I wanted to sort of touch base on, and I think Darcy stepped off, so I may not have anybody who could answer it well. But, I was curious for those of you, and maybe just even from, provider standpoint, we were, part of access and barriers to care is that, there are waiting lists at a lot of places and a lot of offices. And so particularly, I know our free clinics, many of them have, 4 to 6 month waiting lists. So I'm just kind of curious as to, what individuals are thinking around that. Is that going to mean that, there is this thought of, well, offices could be open longer hours, but at the same time, treatment takes a longer time with all of the extra prep work and additional PPE. So I don't know that the offset, of even adding additional staff time or additional shifts is really going to fix that problem for places who already have waiting lists. So I was just kind of curious as to what anyone's heard from either, being a provider yourself or working with providers, if your community members are going to have a longer wait.
Helen, I can tell you that in my clinic, and of course I know I'm New York, but I think Pennsylvania is going to be facing the same thing. We've already started triaging all of the appointments that had to be canceled, and basically we're considering our entire appointment book has been cleared, because we're going to have to sort of start fresh with, okay, who was scheduled, what were they scheduled for, reviewing their x-rays and triaging, these are the people we need to get in first, blah, 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 and then trying to contact and coordinate them coming in. We have, currently, we only have 2 treatment rooms, and the space coming in to get to those rooms, there's crossover. So we have to make sure that this room is seated, the door is closed, and everybody is out of the way before the next one can come. And so we're going to have to be spreading our appointments out in a way that we didn't before. We are going to be seeing less people in a day, and we may even be coming in and out in shifts so that only half of the staff is even there at a time. And unfortunately, with the scheduling, trying to increase your hours, you then run in, when I was in private practice and other clinics, traditionally, when we tried to have Saturday or nighttime hours, everybody wanted those appointments, but then they forgot, oh, I have to get home for childcare and this and that. And it's a very difficult to extend hours when staff has family needs, patients have family needs, transportation can slow down. So we always found that the highest no-show rate we had was when we tried to have those after hours or weekend hours. That was always the worst time. So I think that making sure that the caseworkers who are helping to coordinate some of these appointments, if later appointments are going to be made available, patients have to understand these are very special appointments, and making sure that all the things are in place to help get them there, which we're already having trouble with on a regular basis, because we know all the barriers. That's why we're all in this conversation. So even trying to look at increasing the hours may not necessarily help solve that.
Interesting. The idea of clearing the book to me is just really, it just blew my mind. Like, so that even if someone has an appointment in October and it's safe to, everybody's back to work, then you're still going to say, no, you don't get that appointment because we still have the backup from May.
Yes, we're basically a clear slate at this point, trying to, because right now, at least in New York, even when we get to reopen, we're still kind of at a very limited emergency, emergent only. And if they say, yes, you can start doing regular care, as you all may know or should know, we're still not sure how aerosol type generating procedures, they're making all these different recommendations, but whether or not you can meet those recommendations. So a lot of it may be still trying to get everybody in and doing a lot of the smart restorations, a lot of silver diamine, that kind of thing. Prophies are going to be all hand scale, and with like a special needs population, we'll be lucky to get a quarter or half of the mouth taken care of that way, because the hygiene is still so poor for so many of them. And those are going to stack up. So where you might have had a single visit before could turn into 2 or 3 visits now. So that's also going to pile up the appointment book. So we're basically, we're starting over. There's no way to say your appointment in 6 months is still going to be your appointment in 6 months. It might, but we're just going to have to go. Yeah, it's crazy. I know, it's crazy.
Yeah, and I'll just say, Helen, that's a similar approach. I mean, I think that most all offices that I've talked to are needing to take that approach. I mean, this has been since mid-March. So every week that goes by, we're digging our hole deeper. And we know that we have oral disease progressing for people at home. So we will have to reevaluate. We'll have to reevaluate everything. And we're going to try to keep pace when we can reopen, but the preventative care and the pro fees is a real kind of bone of contention, that we could, in Pennsylvania, that we could do more intensive work for somebody who's pre-op, but yet we can't clean a kid's teeth. It's very frustrating. So it's going to make, and then as I mentioned, we have this emerging population that's going to be coming to us. So people who have lost insurance, whose economic situation has changed due to COVID, and that's not even in our pipeline yet. So while we don't keep traditional waiting lists at Family First Health, we know that there is unmet demand already that exists in our community, and there's a way that we kind of cycle that in. And with this extended closure, we're going through the exact same process that Alicia's describing. We're really cleaning the schedules and setting up people who are kind of presenting in most need, and trying to work from there under the restrictions that we have. So this will be a year to 18 months, even if we were more fully open today, of trying to catch up. And with the limited capacity in the offices, we won't, as we have to restructure, as Alicia said, we'll have half our teams in some of our larger offices at a time to keep our staff able to distance a bit and manage through those things. So the impact on oral health access, if I wasn't clear enough in my comments, I think is just going to become more dire. That's our only prediction. That would make sense based on our situation right now. And that's with pulling a lot of levers, right? It's doing all the great stuff we can do on the medical side. It's doing all the, the home self-care kinds of prompting. If I can hand fluoride varnish to somebody, that's great. It still doesn't substitute for that interaction with a dental provider for so many of our patients who are in compromised positions to begin with. So this is really a long haul, and what my largest concern, and gosh, I don't want to end on a down note. As I said, I think there's lots we can do, but our workforce was strained to begin with. And as we were in a situation for many, I'll speak only for Family First Health, but if we can't generate revenue to continue to maintain our workforce, we can't have our workforce. And if I lose my workforce now, it's going to make a really insurmountable situation at a community level. And right now we lose on our the changes within dental about $200,000 a month. So that's not a sustainable way to continue. And if I can only bring back people half the time, so those are the scenarios, and I don't mean to belabor it, but those are the scenarios that every dental office, particularly safety net dental offices, are trying to navigate right now in their minds. But knowing that I've got tons of demand out there, got lots of people who need what we do. So how much can I disrupt my workforce, or how much should I? But at the same time, I eventually have to take a look at the financial implications of that. So it's great that we can bill for more things and being reimbursed for more things. It does not substitute for keeping my dental bottom line black, as it's been for 10 years. So, these are going to be the real struggles that are going to exist, and there's likely some advocacy issues, right, mixed in there for PCOH that I can't articulate right now. But on the medical side, we're finding abilities for insurers to understand that there just needs to be influx of dollars into practices to keep them open and doing what they do months from now, not just today. And I think we need to have the same conversations on the dental side, and they're even more critical. In medical, I'm in 80% operations right now already, and we're feeling, that's something that we can do. Dental, I'm at 5%. And I don't see, that's not going to change greatly over the coming couple of months if our restrictions stay the same. I might get to 10% of our prior capacity, but that's not enough to keep doing what we're doing.
And I know that when I've been speaking with other members of the dental community and keeping up with all the ADA and PDA and NISDA and all that, even like with the paycheck protection information and stuff that's out there, they've had to furlough a lot of people or lay them off. And a lot of those those employees may or may not be coming back. So some of these offices are having issues of not knowing whether they're going to even have a full staff when they can reopen, because they've had to furlough people who have then found other opportunities in even different fields that may not be dentistry. And it's very hard to expect that they're just going to drop that and come back to the office. And so that's going to create another problem. I have a question for you, Eve. I was just reading recently that, there's been a decline in children's vaccinations during this whole thing because they're not seeing doctors for their regular care visits. And I know that for a lot of the offices, we do require that they have all of their vaccines in place in order to be seen. And what effect is this going to have on the schools in the fall? Are they going to somehow try to bump up the regular, measles, mumps, rubella? Those aren't being done. And if we do happen to get a COVID vaccine, you think they're going to be requiring that to be able to attend school? I know a lot of the schools in New York have started to say, if you're not vaccinated, we don't care what your excuse is, you're not coming to public school, because of what happened with the measles outbreak. So what do you think? And is there any way that we as oral health professionals can try to spread the word, hey, get your child's vaccines done before there's a big pile up in the fall?
So that is a problem. The visits, what is a lot of practices are doing now, and they're starting to see more patients. Again, I was just talking to TJ Maroon in the western side of the state. And, they're being really creative about doing immunizations in the parking lot, in the car, and such things. And there's the national and the Pennsylvania chapter are putting out a whole lot of information to try and get people to understand that it really is important to get those vaccines done. I don't know what the schools are, I don't know where that's at. I don't know that anybody has thought about that yet in Pennsylvania. I have a question though. And my question is that Healthy Teeth, Healthy Children is going to do an oral health hour sometime in June, after the middle of June, between the last 2-3 weeks in June. And what should we be we've had really good attendance at those sessions. They're Wednesday nights from 8 to 9 o'clock at night. And we've had like 150 or more people on the webinar. What should we put in that webinar for the providers? And here are my questions. One is to tell you, we are telling them they must teach brushing, flossing, no sugar, decrease in sugar, do those prevention things. We're not sure whether we can tell them to put fluoride varnish in. On the eastern side of the state, nobody's allowed to do it. And on the western side of the state, people seem to be putting it on. So in pediatric offices. So I'm not sure what to tell them. We're going to work on, and if you have any suggestions about that. And then what should we tell them? It sounds like we need to tell them that they have got to do the brushing and the flossing, and they have got to call their dentist if the change. Any ideas? Help. And yes, the practice is, the last I heard was about 30% of their normal.
I got to think further about that, Eve. We might have to circle back on that one. That's a loaded question. I would also second, I heard from the HPV work group also for the state said that their vaccines were down 73%. So I definitely. Now,
what I did hear that was very interesting, I was on an advocacy call for the Pennsylvania chapter. And one of the things that they talked about was HPV vaccine, that they were willing to have the pharmacist give it because it's so hard to get the adolescents back. And the interesting thing was that it came that they said, oh, you know, we hear that the dentists that there's somewhere in the state that's trying to get the dentists to do HPV vaccine. I think this might be an ideal time to get the pediatricians to support that, is what I'm saying. And I will push that on our side.
People laugh about that, but the number one cause of HPV related oral cancers now, or the number one is HPV. We're seeing that that's kind of the top leading causer within the oral cancer genre. So getting dentists to be able to do HPV vaccines falls right into the oral cancer prevention and has nothing, you know, and if we can get certified to be able to do that, that would be wonderful. It'd be even better if we could do other vaccines as well. We see people more often, usually, than their medical providers sometimes, so.
Yeah, it's definitely been a topic. We'll give some information. Jess, what did you want to ask something?
I was just going to say, that's okay. Just as something to keep in mind as you're thinking about that vaccine situation. In Pennsylvania, Medicaid participating pediatricians have to leverage the Vaccines for Children's program. So if dentists would begin to use or do vaccines, there's a lot more to it than just pushing the meds. So they would have to adhere by the Vaccines for Children program, and then we would have to figure out a way for dentists to be able to drop claims under CDT, because they're not going to want to use a CPT code. We've been down that road with tobacco cessation. But just something to keep in the back of your mind as you're thinking about operationalizing something like that on a practice level of how maybe this could be done. But there's some different challenges there. And I love the idea. Believe me, I would do just about anything to get more kids, you know, vaccinated the way they should be on the appropriate schedule. But that's something to keep in mind. And it may interfere too with the EPSDT and the health. I forget what the CHIP one is. Healthy families or healthy, I can't remember, their periodicity schedule. Thank you. But just making sure we keep those things in mind as we think through some different delivery systems.
No, you're absolutely right, Jetson. It's really hard to get small family practices to do vaccines because the storage of the vaccine requires a special refrigerator, yet another expense for the dentist. And participation in the immunization registry in the state, which requires a computer and a computerized health record.
Yes.
So more barriers.
We've had calls to the Pennsylvania Immunization Coalition on this very subject, dentists providing the vaccine. Secretary Levine is actually, I'll unofficially say she's okay with that. And I know our state dental director would love to see that happen. So I will tell you guys that it's happening. So that is one way we might be able to address at least access to vaccines, particularly around oral cancer moving forward. Is there any other, I know we're about to run out of time and I want to be mindful of everybody's time. Is there any other sort of last minute or anything you want to share with us or we can address in the last minute or two? Okay. I think that was enough time for the crickets to chirp. With that, we will wrap up today's call, but I do want to, again, thank you all so much for coming, and I hope this was helpful. We need to see and talk to people because that's how we do our work. So please feel free. We'll hop on a call or a video call with you anytime if you want to share ideas or you need help. So please feel free to reach out, and thank you again to everyone for the great conversation today.